being here. Okay, I think we're good. All right. We will begin as we always do by talking about where we have been since our last meeting. We last met on March the 10th. Excuse me, March the 15th. And up until last Friday, in that period, we experienced, oh, I'm sorry, can people just mute if they're not speaking, just so we can get rid of that background? We have experienced 13 additional overdose deaths that our troopers have responded to. And I want to talk a little bit, as we've been doing, just about some of the background of that. In those deaths where we know the cause so far from the medical examiner of the cause of death, we know that 2 were fentanyl deaths, with 1 being a cocaine death. And to give you a little more sense of who those people were, 1 was a young man in his 20s, found at home in his bed by his mother with his girlfriend, who had also overdosed but did survive that overdose. They had gone to a party. They apparently believed they were using cocaine at the party, but were also given meth. Another was a woman in her 50s, again, located at home in her bedroom, this time by her, excuse me, her adult daughter. She had a history of use of crack and was also on an oxycodone prescription. So what we obviously all know, what we often see, that kind of polysubstance use. Another was a man in his 50s with a history of fentanyl use. In this one, his wife heard him in bed, heard him snoring. And then eventually, when she made her way to the room, he was unresponsive. So despite the fact that she called 911, they were not able to resuscitate him. Similarly, a man in his 40s, his girlfriend woke up to hearing him snoring. When she fully woke up and tried to wake him up, again, unresponsive, 911 call was not successful. She knew him to be abusing some sleep medication that he had been prescribed. So we're doing that, really, the dig into what's happening, for 2 reasons. One is to just really show the commonality of what we're seeing and the fact that there is really no demographic that is immune from what's happening. Also, just the impact in terms of, again, we've got that situation of parents finding children, children finding parents, and to look at, are there public messages that we can be getting out there? I'm going to start once again what we know was effective, which was getting out there the fact that hearing that snoring should be a trigger, because we really did have people responding much more quickly to that. And we did see a decline in our numbers, but clearly that message has been lost once again. So I think we'll reach out to Channel 5, who was really helpful in getting that message out before, and get the public service piece. And we'll put up on all of our social media, and then hopefully lots of people will repost that in terms of that message. We also see, and I think this is really a testament to the work, looking as we always do to this year, back to 2022, where we are right now, a little over a quarter of the year in, we are down pretty significantly. We are down 19 deaths from where we were last year at this time. That is a having 10 people in their circle or something that are being impacted. That's a very significant number. So I think that that is a testament to the work that all of you are doing in the communities, because we remember that one year when we had the very significant spike. And one of the things that I want to begin by talking a little bit about is letting people who are new to this meeting is that one of our primary goals is really letting people in the community be in touch with us sharing resources, letting people know what you're doing or what you need. What are the issues that you are seeing in your community? Because we have such a great group of people that whatever issue you have or whatever you need, the likelihood is there's somebody here who can help you with that or who has dealt with that same problem. So to anybody who at any point wants to present, wants to bring some slides, talk about what they're doing, we are happy to have you join that. I also want to talk about, and I mentioned this the last time, the FDA's announcement approving over-the-counter Narcan. Amazing, but keeping in mind that cost is still prohibitive for some people. And right now in Massachusetts, what you are actually paying for that over-the-counter Narcan can vary very dramatically depending on your insurance coverage. So I am asking again for your support of our bill, which is the act relative to the establishment of, for the payment of opioid an opioid stewardship fund. And that is House Bill 193, Senate Bill 1259. That would compel a payment of less than a penny per sale on opioid makers or sellers in Massachusetts. So if you sell opioids in Massachusetts, you would contribute less than 1 penny per sale to this fund that would be used to drive the costs down into the $5 to $7 range. It's modeled on what they do in New York. I really believe that cost should never be a factor in whether somebody can save a family member's life. And if you use your Narcan, you should be able to go and get that replaced for very little cost. The House bill is 193, Senate Bill 1259. And remember, what we know from our legislative partners is that 6 is the magic number. If they hear support from 6 people on a bill, that's what triggers them to look at it. Remember, every legislator represents, you know, a relatively small number of people in their district. If 6 people are sort of calling their attention to a bill, they are then going to go look at that bill. I think it's hard not to support this bill. People are making money on it. We're asking them for less than a penny a sale. I'm very grateful to our legislative supporters on that bill. For those of you who live in their districts, it's Senator Jason Lewis, Representative Kate Donahue, and Representative Simon Cataldo. They are the sponsors of the bill. So particularly if you live in their districts, just let them know that you are supporting that bill. And I then remind you again about the xylazine. We are continuing to see that, you know, branded as sort of a variation on this epidemic that we've been seeing, kind of like a coronavirus mutation. This is something that is incredibly dangerous, and we are definitely seeing, we are hearing from the DEA now that 1 in 3 purchases of drugs on the street in Massachusetts has got xylazine in it. Also, the issues that we're seeing around that on our college campuses. I've been spending some time lately on our college campuses. They are definitely very aware of xylazine being in the purchases that people are making on the street. And I know that Nora just sent me a text wanting to call our attention to the Biden-Harris announcement today about xylazine. So she put a link in the chat to that announcement, calling attention to the danger. All right. We are joined today by a number of presenters that I'm very grateful to have with us. And first up, we have 2 guests joining us from the Office of Attorney General Andrea Campbell, our new Attorney General. We're warmly welcoming Assistant Attorney General Nina Cohen, who joins us from the Healthcare Division. And Nina's a graduate of Yale Law School, clerked for the First Circuit before she joined the AG's office. And Catherine Madden, who's the project manager in the AG's Policy and Government Affairs Division, who is working on their opioid abatement policies. And Nina's going to talk to us first about the now finalized statewide opioid settlement the new municipal sign-on process. And that is particularly timely, and one of the reasons we're especially happy to have her here today, because there are some upcoming deadlines for your communities around accessing those abatement funds. And then Catherine's going to chat with us about a new multi-municipality nonprofit initiative that's coming out of Central Mass. So I'm happy to have both of them here to talk with us, both about how you can get some money for your community and then this nonprofit that's arising. So Nina?
I believe Nina is having some technical difficulties at the moment. So if whoever was
Catherine?
following her could.
Is Catherine with us? I know Nina she was having trouble and then she popped in. She must have popped back out. Is Catherine on with us? No? All right. We are then, I think, going to switch up the orders because I see Aaron here and he has his video on and I'm hoping has audio. Aaron Katz is the Vice President at Elliott Community Service, Human Services. So welcome. Aaron brings substantial experience at Elliott. He previously worked as the Director of their Mental Health Services and Director of Quality and Outcomes. And I'm really happy to have Aaron here. As many of you know, Elliott has been an incredible partner with us, has helped us to get so many of our programs, our diversion and drug court programs, off the ground. So I'm really happy about that. And Aaron's going to talk to us about an update on the recently launched community-based health centers from Elliott's perspective. Elliott has a new community-based health center for community members in Melrose, Wakefield, and Stoneham. And this model is really, I think, based on what all of us would hope to have, which is local access to routine, urgent, and crisis treatment for mental health conditions and substance use disorder. And it really is important to make these services accessible, available, equitable, and rooted in your own community. And I think we've all seen over the last couple of years how much more important that is. And then at some point, we'll also have VinFen and Cambridge Health Alliance come and talk to us about the services that they are providing. So Aaron, I'm really happy to have you with us. And thank you for pitch hitting in quickly while we get our tech piece under control.
Yeah, no problem. Thank you for having me. And I see my yellow box is lit up, so that means my sound is working. So great. I'm going to share some slides just to run through, and then I'm happy to take some questions too. Okay, there we go. So CBHC, I'm just going to do a brief overview. I'll talk a little bit about Elliott CBHC, but the CBHC programs launched on January 3rd. These are part of the state's redesign of behavioral health services in part of the roadmap. I think the big take-home message on CBHCs is this idea of there's no wrong door for people to access services. CBHC should be acting as a streamline and either providing services themselves, which I'll get into what Elliott's able to do and what we are doing, or being able to make sure people get treatment that they need in the community. So Elliott has two CBHC contracts. We have the North Essex contract, which is sort of Peabody all the way to Gloucester, then up to Haverhill. So it's sort of the North Essex is what they gave it. The name, and then Tri-City, which is the name the state gave, which covers Wakefield, Melrose, Stoneham, Reading, North Reading, Lynn, and Salem. It does not include Everett, Malden, or Medford. Those are under the CHA umbrella. For us, and CBHCs, we are looking to have integrated mental health and addiction treatment. Our hours are extended. We are 24/7. We are able to do medication-assisted treatment. We're able to do crisis evaluation. We're able to start people on meds and get them into therapy and other treatments right away. At Elliott, our focus really is on evidence-based treatments and providing behavioral health services that are seeped in evidence that we can then produce some outcomes on. And I'm happy to take questions on that, but I won't go into too much detail, but something I can happy to nerd out with folks on if they want to. Another key thing in this redesign is that CBHCs and the old ESPs, now called MCIs, Mobile Crisis Intervention, are not in the EDs. The EDs are now responsible for their own behavioral health evaluations and interventions. So this is, the state's goal is to reduce the number of people going to EDs by building up community-based services through the CBHCs. Another key component in this is creating access. So having access to behavioral health and medication-assisted treatment and substance abuse treatment is key in this. And so that's sort of what we're focused on here, in particular at Elliott. And then there's a new level of care in the system called YCCS, which is Youth CCS, and I've got a slide on acronyms, so I can show you that. So for us at Elliott, we are definitely focused on not turning people away. If someone's coming into us and they're in crisis, or their kid is in crisis, or they're in need of treatment for their addiction, regardless of their insurance, we are treating them. The CBHCs right now are only being reimbursed by Mass Health, so private insurers are not necessarily paying for these services. But I can say at Elliott, we are serving those people regardless of insurance. But if someone calls us and they're, looking, they're on a wait list at MGH because, they're struggling with depression and they've got Blue Cross Blue Shield, we might not serve those folks because the payers, those private insurers aren't paying those. But if that same person comes through because they're suicidal, we'll provide that treatment. So big component of what we're doing is we're doing a lot of triaging. We're starting services right away. We are trying to solve homelessness and other issues related to social determinants within CBHC. So we've pulled in our homeless team to be at our CBHCs to help house people and solve other life problems right away. So we're not just solving mental health issues. We've implemented all sorts of new trainings. We are also embraced something called Zero Suicide, which is a way to organize yourself to prevent suicides and actually treat suicidality. And that's something we've implemented already. And then we're doing team-based care. And so our treatment really is about teams and moving away from the old ways behavioral health centers have been organized. This is a list of our catchment area. I think most people here only care about that Tri-City catchment area. I think I named all of the towns before. Hopefully I didn't leave anyone out. This is my list of acronyms for folks. So CBHC stands for Community Behavioral Health Center Programs, sort of the umbrella of all of these services. The MCIs, so the AMCI and the YMCIs are the mobile crisis intervention. So that for us is the evaluation process related to hospitalizations, as well as detox, and as well as getting people into urgent treatment right away. We then have something called CCS, or Adult Community Crisis Stabilization. We have two of these units, one here in Lynn, which is a 7-bed, and then one in Danvers, which is 6 beds. And then we have, we're in the process of starting something called Youth CCS, so Youth Community Crisis Stabilization. So our urgent care is really focused on crisis evaluation and safety planning. We're working with people who otherwise would be going to an ED. So these are people who need some sort of treatment right away to keep them out of the ED, usually related to suicidality, psychosis, addiction, or some other life critical needs that we need to work on. Our entire urgent care team is focused on, reducing suicidality, as I said. So these are some of the tools that we use to do that. And that's, related to making sure, people don't have guns in their home, making sure we're safety planning. Something I just want to point out is this thing called the SAFE-T, which is actually an assessment for suicidality that we do on every single person who walks through the door. And then the last thing, this thing called CAMS, which is the treatment for suicidality, which we've trained clinicians to do. These are some of the treatments we've implemented to date within CBHC here at Elliott and sort of our framework. So we're assessing people, we're getting a good diagnostic picture, we're starting medications right away, whether that's medications for their addiction or medications related to the psychotic illness. We're doing groups, we're running tons of groups for both kids and families and adults. We're doing individual skills coaching, so it's not just therapy once a week and medications once a month. We're providing really intensive treatment, working with people on goals, and then trying to stay family focused as much as we can. This is just a little summary on our medication services. Our urgent care has nurse practitioners embedded both for adults and for kids. So we are looking to get medications going for folks right away. In Lynn, we have been able to obtain a medical license. So we have a clinic license, a substance abuse license, a BSAS license, and a medical license. The reason we have the medical license is so that we can hold and purchase medications from a distributor so that we can start things like Suboxone right away, or medications if someone comes in and they're psychotic, we can medicate them here, and again, to avoid the ED. In Danvers, we're in a too small of a location. Our clinical license is too small for a medical facility, so we're actually moving over the summer. So Danvers will have that same setup by August. This is just a summary. I won't read this slide at you. I sort of said this already, but this is something unique to Elliott that we understand that people in a behavioral health crisis of any sort or in need of behavioral health services have other needs as well. And so we are trying to solve those to the degree we can at the front door. So our urgent care is really set up to engage people into treatment, provide treatment for about 6 weeks, and then transfer them internally, likely, to an internal CBHC team, which we call a care team. This is just a summary of our crisis stabilization units. So we've got those 2, and then we're building 2 youth units, hopefully to have those online sometime in the fall. This is just some of our evidence-based treatments and trainings we've done. I won't spend too much time on these, other than to say, we do actually have these up and going, and we are actually have implemented these at this point. And these are some of the groups we're running as well. And again, they all sort of relate back to those trainings and treatments that we're doing. In terms of our teams, we've got a prescriber on every one of our teams. They are able to do medication-assisted treatment, and they're doing that already. In Lynn, we have 3 nurse practitioners who speak Spanish. We have several case managers that speak Spanish. We know that's a huge need in this catchment area. And these are our phone numbers. So, there's really one door to come in. And so for the Tri-City area, which applies to this group, our number is sort of convenient, 800-988-1111. And then if the North Essex numbers there as well. So I'm happy to take any questions, or, if I missed anything, someone tell me.
That was great, Aaron. Thank you. Those are amazing array of services. People have questions, comments? Ready.
And just one quick
Paul?
comment, if I can.
Yep. Oh, David, yeah, go ahead.
Okay, for those of you that just heard Aaron speak, Aaron was a guest on our local television show about a week ago, and he was an amazing guest. So for those people that want to hear a little bit more about what Aaron and Elliott Services do, they can just go to Google and type in America in Crisis, Breaking the Cycle of Addiction, Aaron Katz, episode 33. He did an amazing job in speaking really into detail about what he spoke about today. So if somebody wants an opportunity to hear more of Aaron and get more in depth, I would recommend you go on and check it out.
Thank you. Paul, did you have a question?
Yes. Hey, Aaron, how you doing? I was wondering, I saw something with youth crisis destabilization, the youth CSS. Is that up and running now? And if not, when would we be looking at having that running, and what would be the age range for there?
Sure. Yeah, great question. So there are some youth CCS open statewide. So there's one in Taunton, there's one in the city. Ours, so we are going to operate two. One will be for kids 13 and under, and another 13 and 14 and above kind of thing.
Okay.
They are we are trying to place those in together in one facility. And so we have a site that we're working towards to have open for the fall. Currently, VinFen is trying to get one open in the Lowell area, and they actually might get it open over the summer. So the area might have access to one before that.
Thank you.
And there's a question from Devin. What are you doing about follow-up care? Are you using any referral software, such as a software she mentions, which is Unite Us, to do sort of tracking of people?
So we don't use that particular platform. We have our EMR, which is a company called EHANA. They're local in Massachusetts, and they've built a system for us so that we can do that. And then actually we use some, I don't know if folks know Monday.com, which is a project management tool. So we've built that to do that sort of tracking and communication internally. But we're not part of a larger system. We are tracking people though. So, if someone comes in through a crisis evaluation, we are then providing follow-up care and tracking that. We do use some ADT systems. So systems that, if someone goes to an ED and there's a ping or their Mass Health card is pinged, we have the ability to get those sort of alerts. We use two systems for that. So we can track folks that way as well.
Anybody else? All right, Erin, thank you. Thank you. We are always very grateful to Elliot. They've been a great partner to us, so thank you. All right, turning to another great partner, and it is amazing to me when I read this to see that it's been 7 years. We have Pamela Huntley and Mary Beth Murphy here today with us. And this is kind of an example. Pam and I talked recently at the Lowell Women's History Month breakfast, and they wanted to come and share some developments. Many of you are familiar with Megan's House. It opened in 2015 in Lowell. It was an old school that was completely rehabbed, and it now does residential treatment for up to 26 young women who are navigating substance use disorder. The foundation also runs Erin's House, which is a Mass certified success sober home, which is in Drake-it, and that's less than a mile from Megan's House. So Pam serves as the executive director and Mary Beth serves as the program director. They're going to talk a little bit about what they're doing, some of the new developments, and I really recommend that you listen because they also are going to talk about some things that are available. And, we're always looking for residential beds and placements for people, and Megan's House has had a great track record. So thank you both for being here.
Thank you, Marion.
Nope, there we go. All right, great. Yeah, I'm just very happy technology is working some places today. Thank you.
Thank you.
Good morning, everybody. Thank you, Marion, for having us today. It's been a while. So in 2019, I took the position as the executive director at Megan's House. And as DA Ryan said, Mary Beth Murphy is here, who many of you know. She's the director of programming, and she's responsible for developing and opening Megan's House in 2015. So we do have a brief presentation this morning. For those of you who are new to this meeting, I'm just going to go over a quick agenda, give you a little bit about who we are, and then just talk about our programs. Is somebody moving the slides though? Okay. So a little bit about who we are, our residential program, our success home, Erin's House, and then the new success home we're opening, which will be called Emma's House. Next slide. Can we change this slide?
Maybe not. Yep, there we go.
Okay, so our mission at the Megan House Foundation is to improve the quality of life for our residents through evidence-based treatment programs that emphasize individual dignity, self-respect, and empowerment. So that's kind of like how we live and breathe by our programs. Next. So this is a little repetitive, but in 2015, we opened as a therapeutic community for young women who suffer from substance use disorder and co-occurring disorders. So we have a 26-bed program licensed through BSAS. The length of stay for our residents is 6 months to 1 year. We serve women 18 to 26, and currently we have a waiver to accept women up to 28. Megan's House will accept pregnant women. However, no children are allowed in any of our programs. So next slide. So the criteria for admission, the residents must be detoxed and stabilized. And based on the assessment, one of our staff will deem the appropriate level of care, whether it's Megan's House or an appropriate referral will be made to meet the person's need. Substance use disorder needs to be the primary diagnosis. However, we also work with co-occurring disorders. And the assessment tool that we use is the ASAM criteria developed by the Society of Addiction Medicine. Next.
Do you want me to speak to this, Pam?
Yeah, we just need the next slide. Oh, there we go.
All right, we're lurching a little bit.
Good morning,
Okay,
everybody.
sorry.
At Megan's House, which is really unique and amazing, is that we have a licensed clinician in-house, so we are able to provide all these services within our facility. So we do provide the intensive therapeutic services. We do individual therapy as well as group therapy. So group therapy could be psychoeducational, it could be therapeutic. We have an expressive art therapist that's her primary. So the young ladies get different outlets of how they can express themselves and work on the underlying issues that might be fueling their addiction. Next slide, please. Thank you. So we practice CBT, EMDR. Our clinician is certified with EMDR, and those that know it, it is to address really a lot of multifaceted layers of trauma. And so she's done a lot of certification with that and training, because unfortunately, as we all know, there's so much trauma involved with people that suffer with substance use disorders. And like I said, the expressive art therapy, and we all do trauma-informed care, meaning even if someone doesn't say they have trauma, you assume they have experienced trauma and you address them appropriately. This is with the treatment plans. So we do individualized treatment plans. There is nothing cookie cutter here. And they focus on their strengths, their challenges, their needs, their goals, and what interventions, what therapeutic and behavioral modification interventions that we can do with these young ladies. And so they work with her individually. And then we also focus with a goals group that they have to work sometimes on their own. So that it is focused on their strengths and what they want out of treatment and for themselves. We have case management, and she's a busy woman, I just have to say, and it's with the life skills. So the minute they walk in the door, we are either getting their ID, their birth certificate, a license, a dentist appointment, an eye appointment. Typically when they come in, they have nothing. And so that's first and foremost, is to get their basic health needs met, and also what they'll need to move forward for education or a job. As they progress through treatment, then she will work on budgeting and the medical appointments, how to make them, how to keep them, sustaining their mental health and medication management, their time management, their daily schedules. So it's a lot. If you think of somebody that hasn't done anything in probably 5 years, to learn how to navigate can be very challenging. So they do have intensive case management here that helps support that navigation. Our first home is Erin's house, our sober home. We call it a success home. However, we are contracted with the state and it is transitional supportive housing. So case management is provided there. And it's affordable housing. They can live there up to 2 years. And they have to come from either residential treatment or so forth, so that they have 60 days of recovery. But they live in the home, and with the support of case management, their goal is to eventually to transition out into the community and be independent and empowered. That's our goal for these young ladies. At the end of the day, is for them to be independent and empowered. So this is just the second continuum of care after the intensive treatment. So I think this sums up, because I had already said it, with the mental health, the financial, secure and employment. Even after doing like 6 months or 9 months or up to a year at Megan's house, which is very intensive, when they transition to the success home, it's still challenging because all of a sudden they have to be responsible for everything and they have a lot of freedom. So it's great that they have somebody there that meets with them monthly, does treatment, not treatment plans, but goal planning with these young ladies, helping them budget. And if they're looking to get their driver's license, purchase a car. I mean, it's pretty amazing when they move into one of our success homes, how many of them have been able to buy a car and move on into an apartment that is permanent for them. So that is the second step of the continuum of care after the intensive treatment. Our new home, which we are extremely excited about, is being renovated, that we purchased. It is here in Lowell. We have not disclosed the address yet, so stay tuned. But it is being renovated and it will mirror what we offer at Erin's house. So we'll have a staff with the support of case management, and that will help them, navigate through their new phase of their recovery. Sorry, I lost my word there. For their new phase of recovery. So we also have a contract. We already got a contract with BSAS so that they partially fund us, and it will be, again, a transitional supportive housing. So these young ladies can live somewhere safe, healthy, clean, and get the supports that they need. The eligibility for this is, again, they have to be 18 or older and they have to have 60 days of sobriety. Substance use disorder has to be the primary diagnosis, whereas that's our focus. They're able to maintain mental stability and live in a community setting. But with that said, we've had some young ladies come in and fail to show up for appointments or to take their medications. And what we'll do is get them reestablished. If they need to go into a CSS and stabilize for a little bit, then we work with them. We do not kick them out. They don't lose their bed. We've had people that have relapsed and they've gone into detox for a few days and we take them back. So we do work with relapse in all of our settings because our goal is to get them back on track and sober. The unfortunate thing is if they bring substances into the home and put others at risk, then we have to discharge them, terminate them. But we do work with the mental health. Unfortunately, it's often that they might change their meds, decide they don't need their meds or whatever, or relapse. And that's what the staff does at these facilities to get them back on track. The individual has to have a desire for one's recovery and to reintegrate back into society, which means they have to be working towards something after, like having employment or volunteering or attending school. We have worked with many other, oh my God, I'm losing my words, sorry, with other scholarship potentials with them, and we're able to help fund if they can't when they come into our success homes, but they have to be active participants in the process. So if you go on our website, there's the application, and we need a reference letter from a treatment provider, an agreement to comply with mandatory drug testing and breathalyzer, and experiencing housing instability. So it looks like they have to come in and they're perfect, but it's far from, because we work with a lot of them that hit bumps in the road, and that's our goal, is to get them back on track. And I think that's it.
Thanks,
Any
Mary Beth.
questions?
Questions, comments for Pam or Mary Beth? Okay, can you see that question in regards to
I can.
relapse, women relapsing when they're at Erin's or Megan's house?
Unfortunately, both. Because when they're in Megan's house, they are able to go on passes as they progress through the treatment, and they go on passes. And unfortunately, they relapse. At Erin's house, they have a lot of freedom and so forth. And unfortunately, it's part of the disease. Not that everyone has to relapse, but we understand it and we work with it. It's not an automatic goodbye. We want to try to get them back on track, stabilize, reevaluate, and help the individuals to get back on track.
And there's a question about the fees. What are the fees, and do you take insurance? Is it private pay?
Okay. For Megan's house, we are funded fully with BSAS. So currently Mass Health providers have to fund for it. If the individual has private insurance, then I bill the state. So no, at Megan's house, there is no cost. At the success homes, yes, they do have to pay to live there. It's $175 a week. However, if somebody's struggling with that, we have been very instrumental of getting scholarships and working that out. We have done scholarships from our foundation. We've done scholarships. There are an amazing amount of resources out there that can help these young ladies. And just keeping in mind also, it is 18 plus, and but we tend to try to gear towards the younger with the cohort, because they work together and they grow together. But that's not to say that we will not explore other potential applicants.
And are all the people at
No.
Erin's house graduates? No.
No, we open it up. No, we have, no. Is it common for them to filter there? Yes, because they're very familiar with it and they know the other residents there. But no, the applicant process is open to everybody. And we would never choose a Megan's house resident over somebody else if they've been on the wait list.
Anybody else? Thank you so much, both of you. Thank you. And thanks for
Thank
being
you.
so flexible about jumping in there. I am so happy to see Nina, and I'm hoping, I don't see Catherine, but I think Catherine's here. And you missed all of the nice things that I had to say and how important it was for everybody to learn about the deadlines and the settlement, and also to talk about the nonprofit that's come out in the middle part of the state. So Nina, I'm going to turn it over to you. Welcome.
Thank you so much. Can you hear me?
Yes.
You can hear me? You can see
Yep.
me?
Yep.
Okay, so it's a pleasure to be here. I am Nina Cohen. I'm an Assistant Attorney General in the Healthcare Division of the Attorney General's Office. And my colleague, Catherine Madden, may be joining us depending on whether or not tech issues allow. But it is a pleasure to be here. And I'm sorry, DA Ryan, to have missed your introduction. I got a little bit of a relay from someone else. I'm terribly sorry to hear there have been more overdoses, and it's very moving to hear what I just heard from Ms. Murphy about all of your sort of direct services work with this population and everyone who is struggling. And so I am going to discuss sort of another aspect of the state's work on the opioid crisis. It's a pleasure to do so. So with that, I am presenting today on the AGO's opioid settlements, which you've probably heard something about, and I will give you.
Nina, you know what? If I can just interrupt one sec, I think when you're facing straight at the camera and closer, we can hear you better. Because
Okay,
otherwise it fades out a little bit.
all right, is this good?
That's good. I think that's good. Everybody here? I
Okay,
think that's good.
thank you so much. I'm sorry. Okay, next slide, please. So let me just give a brief overview of what I will be discussing today. So first, I'm going to introduce the major investigations that the AGO has launched and resolved into the major targets of the and basis of these opioid settlements. I will next discuss two of the major finalized statewide settlements, and we'll move on to discuss the new settlement, which leads to the municipal sign-on process and the deadline to which DA Ryan referred, which is in 2 business days. We will discuss it. Any municipal leaders who are in attendance, please give me your ear, especially on this. I will seg into discussing the ORF, which is the opioid recovery and the opioid recovery and remediation fund, which is the state statutory trust into which state funds from the opioid settlements flow. And then we'll conclude by discussing municipal abatement funds, which are the funds that municipalities that sign on to these settlements receive. Okay, next slide, please. Thanks. Okay, so the Attorney General's investigation. There are 3 major categories of defendants: the manufacturers, the distributors, and the pharmacies. So the key findings with respect to the opioid manufacturers is that they use unfair and deceptive sales tactics to aggressively promote opioid prescriptions, including tens of thousands of in-person sales calls to Massachusetts prescribers, which resulted in a flood of inappropriate prescriptions. Meanwhile, the opioid distributors failed to implement adequate suspicious order monitoring systems, ignored red flags, and shipped thousands of suspicious orders to pharmacies across the state. Meanwhile, the pharmacies across the state dispensed these suspicious prescriptions without sufficient regard for their legitimacy and in derogation of their legal responsibilities. And the resulting tragedy is unfortunately not news to any of you in this audience, but this misconduct enabled and perpetuated vast increases in opioid overdispensing and diversion, and multiplied the incidence of substance use disorder and death throughout the Commonwealth. And residents continue to suffer. Just by the numbers, from 2009 to September 2021, state records show that over 18,000 Massachusetts residents died of opioid-related overdoses, and more than almost 70% of those people, nearly 13,000 Massachusetts residents, filled a prescription for a Schedule II opioid written by a Massachusetts prescriber. Can you hear me? I just got a message that it's difficult.
Yeah, it's just, it gets, I don't know whether you're moving from the mic, because we can hear you a little bit, and then somehow when you seem to move it, it gets more muffled.
Yeah, okay. I'll say
All right,
aggressive.
that's pretty good right now. People
Okay.
hear now?
Okay, I will not move.
Okay.
Okay, I'm ready for the next slide when you are.
Oh, if I can do one sec, people said they put the closed captioning on. And they've been able to do that. So I think if people are really having trouble,
Oh, I'm
maybe
so
try that option. Okay, sorry, Nina. These are great slides, so I hate anybody to miss.
And I will also send, or I have sent the slides to Madeline to distribute to all of the
Sure.
audience members. So, and my contact information is at the end of the slide. So if anyone, at the end of the PowerPoint, so if anyone has any questions, I encourage you to reach out. And if need be, we're always happy to come back. I'm so sorry about these technical issues. So I guess if it's okay, I'll move on to discuss this slide. So I just want to provide an overview of the settlements globally. You can see from this chart that we expect that the conclusion of the settlements that we are now working to finalize, we expect over $900 million in anticipated settlement funds for prevention, harm reduction, treatment, and recovery services to flow to Massachusetts. So just to discuss a couple of those settlements, one is with McKinsey, the consultancy, and that goes just to the state, to the ORF, which we'll discuss in greater detail in a few minutes. Those payments started in 2021, and will over time amount to $13 million. Next are the Johnson & Johnson and distributors settlements, which we will also discuss in greater detail and which you may be aware. Those funds are split between the ORC and the municipalities, and payments on those funds started to go out to everyone in 2022 and amount to a global total, or will in time amount to a global total of $525 million. And then there are the settlements that we are working to finalize right now and for which we need your help. We'll get to that with Teva, Allergan, CVS, Walgreens, and Walmart. Those again will be split. Those funds will again be split between the ORC and municipalities. And payment is projected to start this summer and will over time, I think over 10 years, amount to $421 million. Okay, next slide. Thanks. Okay, so let's discuss two of the major finalized opioid settlements. In 2021, the AGO finalized settlements with Johnson & Johnson, also called J&J, and the distributors, specifically McKesson, Cardinal, and AmerisourceBergen. And nearly all cities and towns in Massachusetts signed releases and are thus participating in these settlements and receiving funds, which they began directly receiving this past summer of 2022. And as of March 31st, 2023, over $42 million have been paid out to Massachusetts cities and towns from the distributor and J&J settlements. Okay, next slide. So the new settlements, these are the ones we are working to finalize. The AGO has reached settlements in principle with the following: pharmacies, CVS, Walgreens, and Walmart, and manufacturers, Allergan and Teva. Now, this is where you come in. In order to receive payment under these settlements, Massachusetts cities and towns, as well as eligible special districts, must sign on to the settlements by April 18th, 2023. That is this coming Tuesday, so in 2 business days, essentially. If you could advance to the next slide, please, I will tell you more about the sign-on process. So municipalities were sent participation forms and instructions for completing those forms by Libris, which is the settlement administrator, on February 9th. And any municipalities that would like to participate in the settlement agreements and receive payments, as I said, must sign on and return the forms to Libris by April 18th. And it's critical that we meet this deadline to ensure that the Commonwealth and municipalities receive the maximum amount of abatement funds. Next slide, please. Just to get into a little more detail, municipalities have to sign and return a participation form for each settlement in which they would like to participate. But just to get a little more granular here, the Allergan and Teva settlements have a shared participation form, while each of the other 3 settlements, CVS, Walgreens, and Walmart, each have separate forms. And the forms submitted for prior settlements like Johnson & Johnson and the distributors are not effective for sign on to the 5-day settlement. So if you suspect that your municipality has not signed on and you would like to, you need to fill out these forms that Libris sent you in February by April 18th. And if you have any questions whatsoever about your status, whether your forms were sent in, if you have misplaced your forms, if you need new forms, please email our office at the healthcare division. We have an opioids team, of which I'm a member. The website is right here, opioidsettlements.mass.gov. We are monitoring it scrupulously, not quite around the clock, but we are closely monitoring it, and we will get back to you very quickly and are here to help in any way we can, including with connecting you with Libris. Okay, next slide, please. Okay, so now I'm going to talk a little more globally about the structure of all of the settlements in which the state and municipalities are sharing funds. So under the state subdivision agreement, which is essentially common to all of the settlements, J&J, the distributors, and the 5 settlements that we are working to finalize, funds from statewide opioid settlements are allocated as follows. 60% goes to the state's opioid recovery and remediation fund. And as you can see, this is a hyperlink, so you can click it and that will take you to their website. And 40% to those of the funds are divided among the state's municipalities to spend on approved programs and strategies. That is also a hyperlink, but we will also be talking in a minute about approved programs and strategies. Okay, next slide, please. So Massachusetts is committed to abatement in a manner that reflects the input of all of our communities, of people who have personal experience with the opioid crisis, of experts in treatment and prevention, and of staff and organizations that are carrying out the abatement work. Massachusetts is also committed to abatement that addresses disparities in existing services and outcomes, improves equity and the health of individuals and communities disadvantaged by race, wealth, and stigma, including through efforts to increase diversity among service providers. Furthermore, Massachusetts is committed to abatement that addresses mental health conditions, substance use disorders, and other behavioral health needs that co-occur with OUD. We are also committed to abatement that leverages programs and services already reimbursed by state agencies and programs, including direct care reimbursed by Mass Health and the State Bureau of Substance. Sorry, do you mind going back? One minute, please. I will just finish that slide. So finally, the last principle that sort of guides Massachusetts abatement strategy is that we encourage innovation that fills gaps and shortcomings in existing programs. And I really want to underline this. We want to take advantage of the flexibility that these settlements and their structure allows for municipalities to experiment within the boundaries of approved uses to best serve their needs. I don't know, the PowerPoint is not showing up on my screen anymore. I don't know if you can pull it up again. If not, I can just should I keep going, DRI, and I can.
Okay, I think Madeline's trying, she's just having trouble getting it back up there again.
If need be, I can present without it. I can also pull it up on my other screen to guide me. I'm so sorry about these tech issues, everyone.
Hello?
Can you hear me?
Yeah. Okay. All right, Nina was trying to get back to one of her slides, but she can't. Let me just get back to her. Okay. I'm sorry, Nina, somehow they can't get it back up again.
Okay, so do you want me to just present without?
Yeah, that'd be great.
Okay,
Yeah.
I have
Our internet is somehow crashed, so they can't get back at all.
I've been there. So I have the slides pulled up on my second screen so I can sort of refer to them. So the next thing that I was going to introduce is the ORF, which is the state statutory trust. I apologize for having to look away from the microphone a little bit just to refer with my slides. So the ORF is a statutory trust that was established in January 2020 when Governor Baker signed Chapter 309 of the Acts of 2020 into law. And the ORF is charged with developing recommendations for the expenditure of the Opioid Recovery and Remediation Trust Fund. So that's the state's trust fund for settlement fund to mitigate the impacts of the opioid in the Commonwealth. It's chaired by an advisory council, or it's governed by an advisory council, I apologize, chaired by the Secretary of Health and Human Services with 10 municipal appointees who are appointed by the Massachusetts Municipal Association and another 10 state appointees who are appointed by the governor and AG together who oversee the fund. And all appointees are qualified by personal experience or by professional expertise in OUD. Either some of them are lawyers, others are public health experts, and still others are physicians. A little more on the ORF. They've developed 5 sort of key strategies for how they're dispersing and prioritizing their funding. The first is expansion of harm reduction services. The second is increased access to methadone. The third is expansion of supportive housing programs, including low threshold housing. And the fourth is community outreach and engagement. And finally, the fifth strategy is loan repayment for workers in an array of different substance abuse settings and services. Oh, excellent. I was on the next slide. I don't know if you can move it to the next slide. Perfect. Thank you. Thank you so much. I really appreciate it. Sorry about that, everyone. Okay. So, sorry, I just didn't get chat. So the org has retained KPMG, which is another consultancy, to develop a 3-year strategic plan to guide the remainder of statewide org spending. And if you have questions about the org, which also distributes funds to municipalities in some context, please contact them. This is their email address. Next slide, please. Now, I wanted to give an example of some of the org's work. One of their priorities is increased access to methadone through mobile methadone services. And this is, you can see on the screen, the Wellfleet Yarmouth mobile methadone van, which was launched in fall 2022 and is partially funded by the org. And it provides methadone access and other care services to Yarmouth, Wellfleet, and the Outer Cape region, where those services were previously really spotty and scarce. Okay, the next slide, please. Moving on to municipal abatement funds. So first we'll start out with the financial details. As we discussed earlier, under the state subdivision agreement, 40% of funds from these settlements are allocated to municipalities to expend on approved programs and strategies, which I'll discuss in greater detail in the next slide, but that hyperlink sends you to the state subdivision agreement where you can read in detail about what are approved programs and strategies. Participating municipalities, you look up how much money they've been allotted in all previous and ongoing or inchoate settlements on the AGO website. This is also a link to where you can do that. Municipalities, importantly, are encouraged to pool resources and collaborate with one another, including by leveraging existing shared services infrastructure. I'll talk about that in a minute. My colleague Catherine was going to present on a particular project that she knows in detail. I will do my best. I think that she's having internet issues, so we'll get there. Municipalities that receive more than $35,000 per year are required to report how they're spending their funds to EOHHS, while municipalities who receive less than $35,000 are encouraged to report, because that really does give other municipalities inspiration and ideas and of how they might use these funds. The more reporting, the more examples there are and exemplars for other municipalities to use. Reporting begins this summer, and I've included a link to the draft municipal reporting form, which is yet to be totally finalized and which will be submitted through a web-based. Next slide, please. Okay, thank you. So let's talk a little bit about approved municipal abatement strategies. Abatements, these are abatement funds allocated to municipalities must be used to implement the strategies set forth in the state subdivision agreement. Again, another link to it, including reasonable workforce costs necessary to support enumerated programs and strategies. All funds must be used to supplement and strengthen resources for prevention, harm reduction, treatment, and recovery. And again, here's a link in detail of approved programs and strategies. But I just wanted to sort of give you the outline of the general principles that the state subdivision agreement outlines. There are 7 overarching approved strategies, and those are opioid use disorder treatment access, support for people in treatment and recovery, connections to care, harm reduction, services designed to meet the needs of justice-involved individuals, including those who are currently incarcerated and who are about to be or have been recently released from custody, support for pregnant and parenting individuals and their children, and finally, prevention. And while the SSA that's a state subdivision agreement, sets forth 7 areas of approved municipal abatement strategies, each with specific examples of possible interventions and programming. These parameters really are broad, and municipalities are encouraged to think creatively about how to use their funds to best meet their specific needs. Okay, next slide, please. So this is where Catherine was going to jump in, but I think I'm going to have to be a lesser substitute. We wanted to give an example of one such project that is new, but it's interesting because it involves 5 towns pooling their funds from the J&J distributor settlement. Those towns are Gardner, Westminster, Templeton, Ashburn, and Winchester. And not only have these towns pooled their funds together, but they've also partnered with an existing nonprofit called Gamma to provide OED services to their constituents. And the result is that these resources allowed them to fund a new position for a clinical navigator at Gamma, who assesses patients' clinical needs and then makes appropriate referrals for treatment in the community. And before this collaboration, this work was managed entirely by volunteers. And with the introduction of the clinical navigator, referrals that before took days or out-of-state meetings can occur within 24 hours, so expeditiously connecting people with care, ideally in the community. Next slide, please. So I just wanted now to connect you or to make you aware of some resources, particularly those of you in the audience who are involved in municipal management. On our website, we have detailed answers to frequently asked questions, including links to allow you to look up how much money your municipality can anticipate from each of the settlements individually, and the time frame of when those payments will be dispersed. And then that's for the 5 new settlements, but also the previous settlements of the distributor and J&J settlements. And so those links are direct to each of those specifically. Next slide, please. Just a few more resources. More information on approved uses of settlement funds, which is sort of an input process where the state is building its resources and in terms of outlining examples as these funds now are just started to flow in the last 2 years. But BSAS, the Bureau of Substance and Addiction Services website, has gives more color to some of those approved uses, and that link is on the page. And resources on appropriation issues can be found on the Massachusetts Association of Health Boards website at the following link. Next slide, please. So that pretty much concludes my presentation. I'm sorry that Catherine couldn't join to tell you a little more about the Gamma partnership, but if you have any questions at all, particularly about joining the pending settlements, please reach out to us. The municipal sign-on process is ongoing. It terminates on April 18th, and we need everyone to sign on so that we get the maximum amount of funds for you and for the state to address this awful crisis. And you can reach us at, this is the healthcare division at the ADO, you can reach us at maopioidsettlements@mass.gov. You can also reach me if you want to.
Nina, you were a champ.
Oh, thanks. I just want to give my email address to everyone in case you need.
Okay.
It's my first and my last name, nina.cohen@mass.gov. Please email me or the team at any time, and I apologize sincerely for all of the tech issues.
Not your fault at all. And you were a champ, and thank you for everybody for staying with us. You can see why it was so important. We just don't want anybody to miss out on that money. And we will send around the full slide presentation. The slides were great. The closed captioning helped. So thank you. And I apologize that that was so frustrating. I wanted to flag 3 things before we give people a chance to chat. First, I wanted to acknowledge our partners at Newton Wellesley for their work in putting together a really great event with the Community Collaborative's 2nd annual summit. It brought together members and leadership of the 8 councils within Newton Wellesley's Community Collaborative and other people engaged with the hospitals. And I know I saw Lauren and Kim here earlier. I don't want to put them on the spot, but I don't know if you want to chime in with anything about the event if they're still with us. Maybe not. All right. The second is tonight, there is a virtual training taking place from 5 to 6 o'clock. It is called Zeroing In on Xylazine. It's sponsored by Boston Medical Center's Grakin Center for Addiction Training, and the Department of Public Health and the Bureau of Substance Addiction. It's open to everybody, and we will put in the chat the link to register for that. And finally, I want to remind people we have lots of Narcan, and I hate when we get to the end date on that Narcan and we end up not being able to use it. So if you need Narcan, somebody in the community needs Narcan, let us know that. We're happy to get it to that. And finally, our next meeting will be Thursday, May 11th, but I'm happy to give anybody who has who wants to raise something or tell us about something you're doing. Any comments, questions, interesting things people have going on? No, nothing interesting, huh? I think
Marian?
that to be not true. Yes, Bill, I knew you looked like something was happening. How are you?
Look like I had something to raise. I just want to tell people that a long-term project we've been doing with the CBA, which is 27 sober apartments. It started out 10 years ago to take a look at the community and say on that continuum, we have great, programs, recovery homes, sober houses, but we have no recovery long-term apartments. So the 27 apartment complex is almost done. It's on our former clinical site on 555 Merrimack. People have been watching it go up. We are beginning to take applications for that. It is both studio, 1 bedroom, and I think there are several 2 bedrooms. There are some criteria in terms of income and other kinds of things, but being in addiction and being sober, being in recovery is the primary entrance piece for this. So if you're interested, I'll put up Diana Newell's email address. You can write her, and maybe at the next meeting we can go over that and go over it in some detail with the Anjou and tell people about this wonderful addition, I think, to the continuum in Lowell.
That is a great addition. Thank you. Yes, we'll be happy to talk about that at the next meeting. We have the Narcan, and we just put Madeline's email in the chat. Just reach out to us. We're happy to arrange to get that to you. Needham has the forum tonight, and Carol just put that information in the chat. I think that is everything.
Marion?
Yep.
One quick thing, I've got the ADHD meeting, the anti-hate, anti-violence meeting on Thursday, the 11th. Are those dates correct?
The anti-hate, anti-bias is the 18th, I believe.
Okay, the original email was the 11th. Okay, I'll
Maybe,
move
yeah.
that to put
Yeah,
yours in.
I have
Thank you.
that on the 18th. All right.
Awesome, thank you.
Thank you, everybody. Enjoy this beautiful weather. It's going to be like summer for the next couple of days. So thank you all. And thank you for bearing with us today. Thank you.